Medurstand. Understanding medicine.
I'm Professor Aziz Rehman, and I'm going to start a 3-lecture series on potassium disorders. In this one, we will just talk about the basic concepts, why potassium is so important, how is it regulated, how it is distributed in the body, and what are its functions. Very briefly about its bad effects when it gets deranged. But in the subsequent 2 lectures, I will be talking about hypokalemia and hyperkalemia in 2 separate lectures. So let's get started. In introduction, potassium is extremely essential for normal body functions. It is absolutely indispensable. Life is just not possible without a normal potassium level. I mean, of course, it would, within a certain range, body will tolerate it, but without potassium or when it is grossly deranged, life is not possible. And it is very tightly regulated within a very narrow range. We have a very robust multi-layer system to control our potassium despite our unregulated intake, because potassium is present in large quantities in almost all foods, and we never measure when we take it. We could take small amount or we could large amount. Despite that, there is this very robust system of regulating it, and it is kept within a very narrow range. Even slight deviation from the normal range may indicate a potentially serious underlying problem. That is because it is a very efficient system. So even slight derangement would mean that that very efficient system has also been overwhelmed. So I think potassium should always be taken serious. Even slight derangement, you must take some action. You must ponder why it is so, and you must take appropriate action. And even deranged values, they do not go beyond a certain limits. They also stay within a normal limits, because very gross deviation would not be compatible with life. Now this is important. Like if you compare it with glucose could go as low as 50 and as high as 700, and patient may still be alive, whereas potassium could go as low as maybe 2 or 1.5 max and as high as 15 maybe, and then of course patient would be in very serious trouble, or patient may die. So that emphasizes the importance of potassium salt and its values. So very basic concepts of potassium chemistry, and it is actually a metal. Although we see it as, we never see potassium in its pure form in the nature, because it is highly reactive. It is always bound with something. So as such, potassium is a metal with one positive charge, and this is abbreviated as K, and the word is derived from kalium, a Latin word. And it is present in abundance in nature. In our edible things, like in food, all vegetables, all fruits, they have some quantity of potassium, and even animal flesh like meat also has a lot of potassium, because it is primarily an intracellular ion. Even in the nature, there's a lot of potassium in soil, there's a lot of potassium, and potassium is very much needed by the plants. It is present in oceans, so I think it is in abundance. Common compounds which are present, they are potassium chloride, potassium carbonate, potassium hydroxide, and potassium nitrate. And there may be more actually, but these are the common ones. And when we talk about in medicine, we mostly talking about potassium chloride, because potassium chloride is the injectable form, which works very fast. Potassium phosphate may also be clinically relevant, sometimes may be needed in diabetic ketoacidosis. Now, where in the body potassium is found, the total contents are like 1 in 140 grams. In a person of 70 kg, total potassium in the body is 140 gram, and it is mostly present within the cells. You know, our intracellular compartment is about 2/3 of our total fluid compartment. So it's mostly present within the cell, and in the cells, mostly in the muscle cells, but of course all cells, the range is 140 to 150 milliequivalents. It's only slightly less than the sodium concentration in the extracellular compartment. And in the extracellular compartment, potassium is kept within a very narrow range by a very active mechanism, 3.5 to 5 milliequivalents per liter. So anything less than 3.5 would be hypokalemia, and anything more than 5 would be called hyperkalemia. And there are many factors which actually regulate, and just about the distribution, and this picture will explain it better. This is intracellular compartment. 98% of our total potassium is present within the cell. Only 2% is present in the extracellular compartment. Now, the plasma actually represents extracellular compartment, although interstitial fluid is also extracellular compartment, but mostly when we are measuring potassium, we are taking sample from the blood, and so it would represent serum potassium. So remember, we are making judgment of total potassium from a small fraction. So that is why even small fraction in this could mean gross derangement. And body has made a very intelligent system of quick fixes. So potassium is by sodium potassium ATPase actually has made an arrangement that potassium is constantly kept within the cell and sodium is kept outside the cell. And this is required to maintain resting action potential. All excitable tissues like nerves, the neurons, and the muscle cells, cardiac muscles, pacemaker muscles, they all need resting action potential. And it is this further surge of release when there is excitation of these tissues. And there are many other factors actually, like pH and certain drugs, which can shift the potassium from within the cells to the outside. For quick fix adjustment, of course, there is a further regulatory system, but this can make quick fixes. So I'll talk about this a little more detail later. So what are the functions of potassium? Maintaining membrane action potential. And this is important for all excitable tissues, perhaps all cells, I believe. Brain, particularly nerves and cardiac muscle and skeletal muscles and smooth muscles especially, but I think all muscles, all cells, they need membrane action potential. And depolarization of excitable tissues. One example is heart, the other example is muscles. And then numerous other functions which are related with various hormones and enzymes. So it has got actually extremely long list of functions, but these are the main ones and in a summary form. So how is then potassium regulated in the body? Since it is important to keep it within a very narrow range, so nature has made multi-layered arrangement so that potassium must be kept within the normal physiological range. First of all, our dietary intake. Mostly we are taking potassium in more than what our body needs. Because potassium, our food is rich in potassium, both vegetable as well as animal source food, they have very high potassium content. So we are mostly taking extra amount of potassium thanks to our kidneys that is very efficient in excreting the extra amount. I can't imagine somebody who would develop deficiency of potassium just because he or she is not taking enough, except people who are very aged, very elderly, very compromised food intake. They do not take enough food, or they are on what is called tea and toast food. So they may be vulnerable to develop hypokalemia, but most others, they do not. And in excretion part, of course, if kidney is affected, there would be problem. Then kidney plays extremely crucial and central part in the regulation of potassium through renin-angiotensin-aldosterone system. And this also we will talk about in some more detail in subsequent slides. And then there is cellular shift, that I call it quick fix, but because extracellular potassium is perhaps more important than intracellular, both are important. But extracellular, if it goes down, the potassium can come out of the cells, and if extracellular potassium goes up, the potassium can go into the cell to maintain extracellular uh, potassium until kidney can fix it on permanent basis. Then there are many hormones which have effect on this cellular shift. What is the wisdom of nature? We don't really understand. So insulin can push potassium into the cells, and catecholamine can have also some effect, and glucagon have effect. So I think all these things, they can affect our potassium. So that is what I was referring to, multi-layered arrangement to maintain potassium within the narrow range. And this is the main player, the captain of the team. So kidney handling of potassium through aldosterone. Of course, the potassium could go up and could go down depending upon various conditions. If it goes up, then or goes down, appropriate action will be initiated. Now, potassium going up would stimulate aldosterone, and potassium going down will suppress aldosterone production. Now, what is the function of aldosterone? It actually promotes excretion of potassium in the nephron into the tubule, lumen, and the distal tubules. So if there is hyperkalemia, more aldosterone and more potassium is excreted into the urine. Hypokalemia, less aldosterone, more potassium is reabsorbed back or not excreted. So this is how nature maintains potassium in a very, very narrow range. Of course, it may take few hours, because kidney usually takes some time, but it fixes the problem more permanently, whereas cellular shift could do it very quickly, but that is temporary solution. So unless there is something grossly wrong with kidneys, there is almost impossible to have hyperkalemia. If there is massive hyperkalemia, like for example you could have in rhabdomyolysis or tumor lysis syndrome, there may be transient hyperkalemia, but if given some time, kidneys will excrete it. Only when kidneys are deranged, we will develop severe hyperkalemia. So that is how kidney is extremely essential. About quick fixes, and I told you the potassium can go into the cells or out of the cell to maintain extracellular potassium within the physiological range. And this is the list of many conditions, and I have coded them red. Red means the potassium coming out of the cells, and this blue means potassium entering the cells. Okay, so these arrows and this text color, they match with each other. In acidosis, like in diabetic ketoacidosis, other acidosis, potassium will come from within the cell into the extracellular compartment. And in alkalosis, it would go inside the cells. And this actually occurs because in exchange of hydrogen ion, in acid-base imbalance, body wants to correct acidity, wants to bring pH back to normal. So what it does is it borrows potassium, and in exchange gives potassium. It borrows hydrogen ion, but in exchange gives potassium. So this is why in acidosis and alkalosis, potassium goes into the cells or out of the cell. Then tissue breakdown, like rhabdomyolysis, the potassium comes out of the cells. On this side, many hormones and drugs, catecholamines, for example, beta-2 adrenergic stimulation, whether due to some physiological action within the body or if you are given a beta-2 adrenergic drug, both of them can push the potassium into the cells, resulting into small mild hypokalemia. Alpha adrenergic stimulation, though it has got relatively milder effect, but it could do the opposite. Insulin pushes up potassium into the cells, and that I think I'd like to remind you, when in diabetic ketoacidosis, it is always emphasized that once you start giving insulin, but if you don't give potassium, there is a risk of developing hypokalemia, because potassium will be pushed into the cells and you will end up having hypokalemia. So that's why the importance of insulin. Glucagon has got milder but opposite effects. Then vitamin B12 in large doses can also push potassium into the cells. So all these may have some clinical relevance. When you are pondering about the cause of hypokalemia, you must consider all these conditions, including kidney disease. Clinical importance, there could be hypokalemia. In hypokalemia, if it is less than 3.5, basically caused by diuresis and diarrhea and alkalosis and symptoms of muscle weakness, cardiac arrhythmia. But we will have a full lecture on hypokalemia. So very briefly here, in hypokalemia, causes are renal failure, acidosis, rhabdomyolysis, tumor lysis syndrome, and it could cause cardiac arrhythmia and muscular paralysis, especially if somebody already has an underlying heart disease. For patient with heart disease, particularly prone to arrhythmias, the even slightest variation of potassium could be very dangerous. So we are very, very particular about these patients. So how do we measure potassium? We measure in the serum as part of normal electrolytes. We normally order serum electrolytes, and potassium is a standard component of serum electrolytes. So that is how we can measure it, or we can specifically order potassium. So when do we order potassium? Whenever we go for thorough laboratory checkup, we do potassium electrolytes. But particularly in these patients, whenever we suspect a kidney disease, in kidney diseases, mostly it is hyperkalemia, but there are some kidney diseases where it could be hypokalemia, potassium losing nephropathies. So there could be the hypokalemia also, but mostly it is hyperkalemia when kidney is diseased. Acid-base imbalance, electrolyte abnormalities, and trauma. These patients we measure not only once, we actually measure serially because we want to monitor potassium very, very accurately. Then there are various measuring techniques. Ion-specific electrode method is most widely used in the laboratories. This is also better than the previous one, flame photometry, and there are actually more advanced ways, more expensive ways also. When you want potassium to be measured in an extremely precise way, those are used, but they are usually used in the research. It is also possible to measure potassium at point of care, like an ICU, CCU, even in clinics, but these techniques are relatively less precise. So collecting technique and sample timing is also important. This may be particularly important when we are treating patient with cardiac disorder, when we are concerned even slightest variation in potassium. For example, if you apply tourniquet for too long and you ask the patient to move his arm too frequently and for many times, that could raise potassium. And if you take the sample immediately after patient did his exercise, there could be transient rise in potassium. So I think these things are also very important. We must standardize. When we are monitoring it tightly, when we are monitoring in cardiac patient, we must consider these factors also. Now, how do we convert milliequivalents into milligrams? And this is important. I consider it important because we often talk about milliequivalents. But when we talk about replacement, especially the oral form, potassium is usually measured in milligrams. So we need to know how much a milliequivalent is in milligram. So 1 milliequivalent is the milligram divided by 39.1. That is, of course, a smaller weight. So this is how, if you have 780 milligram and you divide it with 39.1, it will turn out to be 19.95 milliequivalents. So this is how you make conversion. So in summary, ladies and gentlemen, first of all, potassium is essential for cellular function, all excitable tissue, particularly nerve transmission and muscle contraction, all type of muscles. And it is also important for many other cells. It is very tightly regulated because gross variation is not compatible with life, so nature has made multi-layered system of its regulation. Understanding its distribution and regulation is key for the clinical management, and in the next 2 lectures, hypokalemia and hyperkalemia, you will appreciate the relevance of this lecture. So I do request you to please join me in the next 2 lectures also. So prompt action would be needed in both hypos and hypers, because even slightest hypo, slightest hyper could actually indicate a serious underlying disease. Thank you very much. This has been Professor Aziz Rehman for Medurstand-Understanding Medicine. I really look forward to see you in my next video related to potassium, hypo and hyperkalemia. Thank you.